Hello, I'm Banu Arun, and on behalf of CME Outfitters, I would like to welcome you to today's educational activity entitled Tackling Barriers to Genomic and Biomarker Testing in Precision Cancer Medicine, Integrating the Latest Evidence into Practice for Community Oncology Clinicians. In this episode, we will be discussing the community oncology approach to genetic testing and biomarker interrogation. Today's program is supported by an educational grant from Merck Sharp and Dome LLC, a subsidiary of Merck & Co. Inc. Now, I would like to introduce the faculty. Again, I'm Banu Arun, professor at the Department of Breast Medical Oncology and co-medical director for clinical cancer genetics at the University of Texas MD Anderson Cancer Center. And joining me today is Dr. Kurt Schalper. He is Associate Professor of Pathology and Medicine and Medical Oncology at Yale School of Medicine. He is also Director of Translational Immuno-Oncology Laboratory at Yale Cancer Center in New Haven. Welcome, Dr. Schalper.
Thank you very much for the invite and the introduction. I'm very happy to be here and look forward to discuss this important topic.
Thank you, Kurt. So let's start by reviewing our learning objectives for today's session. After participating in today's activity, participants should be able to implement best practices in genetic and biomarker testing for cancer immunotherapy. Okay, let's get started. Kurt, could you start us with a definition of what a biomarker is in oncology?
Yes, absolutely. So conceptually, a biomarker is defined as a characteristic that is objectively measured and evaluated as an indicator of a normal biological process, a pathogenic process, or a pharmacological response to a therapeutic intervention. However, this is a very broad definition, and biomarkers can further be classified based on multiple different variables. One very typical is based on the type of specimen. We can define them as tumor biomarkers, blood biomarkers, or other fluids. The second one is relative to the analyte or the molecular substrate in which the biomarker relies on, and there are proteomic biomarkers, genomic, transcriptomics, etc. But then the most clinically relevant classification is based on the purpose of the biomarker. And then we have diagnostic biomarker, pharmacodynamic markers, prognostic biomarkers, and predictive. And I put an asterisk on predictive here because that's really the one that we used mostly in the clinic, which allows us to define treatments or allocate treatments better as opposed to the other biomarkers. So one important thing why biomarkers are relevant is because today the oncology practice is subject to what we initially called the personalized oncology approach or precision medicine approach, in which we're trying not to just treat generically cancer based on anatomic location, but really extract the dominant biological features using an array of different molecular technologies. And you can see here in the slide where we are usually obtaining samples from the tumor or blood or other solutions, and then analyze different analytes, including DNA, RNA, and proteins. The idea of this approach is to be able to identify and pre-select the patients with the highest likelihood of benefit from treatment and the least risk of toxicity. Just as an example of how this actually works in the clinic, you can see an algorithm on the right where after usually diagnosis of cancer in a patient, there are multiple options for what we call ancillary testing. And this ancillary testing can occur in different sample types. As you can see there, liquid biopsy, tumor, or other specimens. The most important point is that different tests are based on, for example, genomic alterations, and examples of that are things like EGFR mutations, KRAS mutations, or in the germline setting can be BRCA mutation, for example, associated with risk. In the protein space, we generally detect biomarkers using immunohistochemistry, and HER2, for example, or PD-L1 are great models of this protein testing. And then the RNA or transcriptomic analysis is a little bit behind, I would say, in the number of approved indications. But in breast cancer, it's actually very common to use recurrence score or assays such as MammaPrint or Oncotype DX. So these are examples of biomarkers that use different samples and different analytes. So now when we look at the landscape of biomarkers that are commonly used in solid tumors, I don't want to go through this list extensively, but you can see on the left side, there are targeted therapies, and PARP inhibitors, which are associated with molecular alterations. And then on the right side, you can see immunotherapy-related biomarkers. And I just put together a list of common tumors, high-frequency malignancies, and you can see that the number of molecular biomarkers, both for targeted therapies and immunotherapies, is actually quite substantial. And this brings up the question of the actual need of sophisticated molecular testing now to actually decide the best treatment for our patients. We're not only relying on a single gene anymore, we're relying on a number of genes and also protein assessments. You can see as an example in lung cancer, there are currently 8 genes for which testing is necessary because there are targeted therapies approved. And then there are immunotherapy biomarkers such as PD-L1 and tumor mutational burden. So again, this is just to exemplify how complex the biomarker landscape has come, and is a very dynamic field, so we need to keep an eye on it.
Sorry, continue. I was going to ask whether you maybe can give an example of EGFR, whether to test it in tumor or plasma, and I understand there are multiple platforms for genomic testing available. So after you give the examples, perhaps we can go into that as an example.
Absolutely, and this is an important question because as there are many biomarkers to measure, there are multiple ways of testing those biomarkers. In this slide, I just summarized popular methods to test for EGFR mutations, and we can see here on the left Sanger sequencing, which is direct sequencing. It's kind of an old-fashioned strategy, but it's still the gold standard in many ways. It has some disadvantages relative to sensitivity, but it's still somewhat used. Then we have qPCR testing, which is in the center, also FDA approved, that can be actually much faster and more sensitive. And then I would say the majority of academic centers and large clinical sites are using what we call next generation sequencing, which is essentially sequencing by synthesis, which allows to do a much deeper sequencing with a capacity also for multiplexing. There are a number of differences in the availability, the cost, and the properties of these tests. And I think it's really important that the oncologists out there are familiar with this method so that they can weigh the relative advantages and disadvantages of them relative to the access they have to test patients. I would say now, because of the number of genes that have been already reported to provide a targeted therapy option or actual clinical benefit, today, most guidelines recommend to actually do multiplex testing. And this has to do with the fact that today, we cannot really afford to do single gene testing just because it takes very long time between one and the next one and the next one, and also because samples tend to be relatively small. So we can't afford to use small or relatively small biopsies to do multiple testing. So in general, and as you can see on the slide, it's advocated that we use multiplex testing in the form of panels. And the panel that you're seeing in the screen is what we call Oncomine version 3. It's a panel including 161 genes that cover most of the genes that are relevant across solid tumors. So this is an example of how with a relatively small specimen, we can extract nucleic acids and do a multiplex biomarker profiling to be able to allocate the patient to treatment or rule out the availability of targeted therapies or immune-related features. Relative to the question of using tumor assays relative to liquid biopsy, it's an important discussion because today we're starting to use more and more liquid assessment. However, it's important to note that the liquid biopsy is great because it's not invasive and can be done longitudinally, but it doesn't really have a very high sensitivity and has a relatively high fraction of false negatives, which is in the neighborhood of 25+%. So today it's not recommended as a diagnostic tool, and we're generally using it more for monitoring. And only can be used for diagnosis when there is an impossibility to get a tumor biopsy. So the current use of liquid biopsy is more in the monitoring than in the diagnosis, and a tissue biopsy is still preferred for diagnosis. Then for monitoring after treatment, liquid biopsy is unparalleled value.
Right. I think that is a very important point, Kurt, because the liquid biopsies are so much easier and it's widely available. One really thinks it could replace it doing in the tumor tissue. But as you pointed out, the 20% false negativity is a high rate for diagnostic purposes. Do you feel that our community oncologists and laboratories are aware of this? I think it's a major distinction that needs to be out there to use it more for monitoring rather than the initial diagnosis?
I think there is slowly the uptake of liquid biopsy is spreading out, and I think with that there is the risk of people overusing it. So I think it's important to understand that just because the name includes biopsy, it doesn't replace an actually tissue biopsy. And I think until now, and until the technologies maybe get better, I think we shouldn't be thinking about replacing it. And this is something we need to be very clear at this point.
Mm-hmm. Thank you. Do you want to tell us a little bit about the EGFR mutations and TKI resistance? I think that is very relevant, and many tests are actually ordered because of this.
Yeah, this is actually quite connected with the liquid biopsy. So one thing that has become evident after broad use of targeted therapies is that there are frequently resistant mechanisms, what we call acquired resistance to targeted therapies. And they can come in different flavors. Sometimes we call on target, which means that the gene that we're targeting with the drug can have secondary mutations, and this EGFR is a good example. There are secondary mutations that mediate resistance, but then there are a number of off-target resistant mechanisms, which are mutations or alterations in other genes. And you can see here in the slide that in the case of resistance to EGFR, TKIs, or tyrosine kinase inhibitors, there are a number of possibilities, such as MET amplification, MET rearrangements, ALK rearrangements, and alteration in other oncogenic pathways. So this brings up the need to actually do consecutive testing. So it's not good enough only to test a baseline and initiate targeted therapy, but now it's also becoming necessary to retest the tumor after acquired resistance and try to identify a treatment option for those patients. This is much accessible using liquid biopsy, as you can imagine, because those patients can be monitored over time. And I think this is a very, very common use of liquid biopsy. Identification of secondary resistant mechanisms, and then with the possibility to include a new treatment for that situation.
Right, thank you. This is very, very, very informative. Now, moving on to the one of the other areas where we use the information to for immune checkpoint inhibitor use. Can you tell us a little bit about that, the mechanism, and how to measure that?
Absolutely. So immunotherapy has expanded quite dramatically over the last years, particularly because of the regulatory approval of two main drug targeting two main pathways, CTLA-4 and PD-1. And there are a number of indications in over 10 tumor types in different clinical settings with approved regimens, including a PD-1 blocking antibody or a PD-L1 blocking antibody or a CTLA-4 blocking antibody. Last year, in March of last year, there was a third checkpoint blocker FDA approval for an inhibitory molecule called LAG-3. The most important thing is that all of these, PD-1, LAG-3, and CTLA-4, are immune inhibitory receptors. So these are receptors that are upregulated in T cells upon activation. And then blocking those inhibitory receptors can reinvigorate T cells to recognize and kill tumor cells. And these responses are very well established to be durable and quite effective in a subset of patients across different disease types. So the critical question is, how can we predict those responses to enhance the benefit and try to minimize toxicity? And one such mechanism that has been well characterized is the expression of PD-L1. So PD-L1 is the ligand of this inhibitory receptor called PD-1 in lymphocytes. And these tumor cells essentially hijack a system that it's meant to be mediating peripheral tolerance to avoid tissue damage. And what it does is the tumor cells upregulate PD-L1, usually based on the sensitivity to interferon gamma produced by lymphocytes. So essentially, upon immune pressure, tumor cells upregulate PD-L1. And that PD-L1 activates and ligates PD-1 receptor on lymphocytes and essentially induce T cell dysfunction and sometimes death. And this is a mechanism by which a number of tumors evade immunity. There are different mechanisms by which tumor cells can upregulate PD-L1. Some we call extrinsic, which is usually cytokine-driven, or intrinsic, which is oncogene-driven. But the bottom line is that this phenomenon can actually happen in the tumor microenvironment and can better be detected looking directly at the expression of PD-L1 in tumor cells and also non-tumor cells. So as you can see here in this image on the left, we have an immunohistochemistry for PD-L1, which is the brown staining. And then on the right side, we have an H&E. And you can see that these tumor cells there are upregulating and overexpressing this protein PD-L1, which is a strong indication that they're evading immunity using this mechanism. In this setting, there have been a number of biomarkers that have been approved to support clinical use of PD-1 and PD-L1 blocking agents based on this staining of PD-L1. And unfortunately, there were each drug or each company developing a drug targeting PD-1 or PD-L1 developed their own PD-L1 immunohistochemistry assay. So we ended up having a number of different assays that are indicated in this slide. You can see there 22C3, 28A, SP263, and so on and so forth. What is interesting is that for both probably biological reasons and technical reasons, we ended up scoring and having cut points for PD-L1 differentially across disease types and across treatments. And you can see here in this algorithm that, for example, for lung cancer, the typical cut point use is 1% and 50% to decide treatment, as opposed to gastric cancer, for example, where there is a very unique scoring system called CPS, or combined positive score. The bottom line here is that there are a number of different ways to test PD-L1, and there's disease-specific and treatment-specific. And I think knowing well what is the disease context and what is the proper assay and interpretation to do is critical to be able to treat the patients correctly. Another interesting thing about PD-L1 is that we have learned the hard way that all these assays are not interchangeable, unfortunately. So when we have compared the scorability of different assays in the same specimens, we have seen prominent deviations across pathologies. So what this indicates is that, unfortunately, we cannot just take one assay and use it for every tumor and every treatment, and there are treatment-specific indications that need to be respected. I have to say, though, the majority of the assays are concordant, and there are a few LDTs or laboratory-developed tests that actually have high concordance with the other, FDA-approved companion diagnostics. The interesting thing that you can also see in this slide is that the scoring systems of PD-L1 are also very different. There are a number of ways. Some scoring systems capture only tumor cells, which we call TPS, or tumor proportional score, and there are combined proportional scores and immune cells and T cells. A long story short, the scoring of PD-L1 is complex, and it's assay dependent and tumor type dependent, and understanding these differences is critical to be able to deploy the optimal treatment in the proper label.
Yeah, Kurt, I think you really made an important point about the cutoffs, concordance, staining, scoring, and especially that different tumor types have different, cutoffs for indications. We, for example, at our institution usually use the NCCN or FDA-approved guidelines and testing assays that is recommended. And I assume you at Yale are doing the same. But of course, a lot of tests are done and ordered outside academic centers in the community. And do you think, and it's good that there is, concordance amongst these, assays and scorings, but do you think there is an importance of educating community sites to make sure that it's important to know the differences in cutoffs and the scoring? And because at the end, treatment decisions for the different tumors will be made based on that.
Absolutely. I think at this point, it's fundamental to have a clear understanding of what are the right assays for the right disease context, and most important, actually, how to score and interpret those results. As an example, we at Yale, we incorporated different assays. We have more than one assay available that cover most of the indications, but then we report them in different ways depending on the tumor context, so that we essentially provide the information to the treating oncologist in the language that is appropriate for that particular disease setting and treatment context. This is, I would say, complicated because, as I just mentioned, this can vary substantially. So I think it's fundamental for the community oncologists to be aware of what is the disease context, what is the right assay to test, and how to interpret that. And I think this is also related with the practice. I also have to say that you need to be careful because some of these indications change over time. So what actually was approved 3 years ago may not be approved anymore, or the indication might have slightly changed. So it's really important to be aware and monitor this type of indications.
Right. It's very dynamic. So following up on the guidelines and the data is definitely very important, especially when new drugs and indications come along with FDA approvals. I want to switch now to another subtopic that relates to tumor mutational burden. Can you tell us about that and how it's assessed and how it's used to decide for immunotherapy and across which tumors? Is it tumor agnostic?
Yes, so this is another interesting immunotherapy-related biomarker, because this is a genetic metric. So it's a genomic biomarker for immunotherapy, and this biomarker emerged essentially by a correlation between the number of mutations that were present in different tumors and the likelihood of response to PD-1 axis blockers. As you can see in the figure, most of the cases with high response rate, more over 30% or so, were tumors that were known to be frequently mutated or have a lot of mutations, like cutaneous squamous cell carcinomas, melanomas, and lung carcinomas, or mismatch repair deficient tumors. So essentially, this correlation opened the possibility that the selection based on the number of mutations was possible. And this was actually demonstrated in Keynote 158, which you can see some of the results in the slide, where a clinical trial was conducted in a tumor agnostic fashion. So every tumor type pretty much, and this was a solid tumor, they were treated based on the baseline analysis of tumor mutational burden. And it was clear that those tumors with more than 10 mutations per megabase using an FDA-approved assay were actually derived more benefit from treatment with PD-1 axis blockers. So this actually drove a tumor agnostic approval of tumor mutational burden with that 10 mutations per megabase cut point for every tumor type across all the span of disease, including pediatric tumors. So this is actually was the first tumor agnostic FDA approval, and as you can imagine, had a substantial impact in the way we handle biomarkers, because every patient potentially after some lines of treatment is susceptible to be tumor mutational burden high and potentially benefit from immune checkpoint blockers.
Right, and regardless tumor type. So that's really a great opportunity for the treating physician, but also the patient. When physicians order the tumor mutation burden assay, which ones should they order? There are several out there. Can you give us some basic comparisons to guide us?
Absolutely. So as you can see in this table, the golden standard or reference for tumor mutational burden is essentially whole exome DNA sequencing, which is not really a clinical grade assay in most situations. This essentially looks at the whole coding region, so we're talking about 20 to 22,000 genes, and then we calculate the number of mutations per megabase of area sequence. As I mentioned, this is not very commonly used in the clinic, although some sites use it, but there are two panel-based assays that have received FDA approval to measure and clinically use tumor mutational burden, which is the Foundation assay and the Sloan Kettering Impact Panel. The particular thing about this assay is that they're relatively large gene panels in which the representation of the number of mutations is considered to be adequate to be able to call the tumor mutational burden as a biomarker. There are a few other ways to obtain this metric, but in general, I think the panel testing is the most used at this point, although the whole exome sequencing is the sort of academic reference for that. One important thing, though, is that it's important to be aware that this panel-based testing is not perfect. And as you can see in the slide, this is data from Checkmate 26 trial that tested nivolumab in patients with advanced non-small cell lung cancer. And for a subset of patients, both exome sequencing data was available in Foundation 1, so panel testing versus whole exome. And you can see there that using both assays in the same specimens, about 10% of cases were misclassified. So this is just to say that although panel testing generally works and there is a label approved for that, you need to be aware that it has a substantial amount of misclassification relative to whole exome sequencing.
Thank you. It's again important to see that there's some discordant. Again, switching to a related topic, how about mismatch repair deficiency? How do we measure that, and how does that affect our treatments? And is that again another pan-cancer tumor agnostic assay?
Yes, so this is another interesting, has a lot of similar elements to tumor mutational burden, because mismatch repair deficiency or microsatellite instability high, it's actually a genomic metric, again, associated with defects in DNA repair and accumulation of non-synonymous mutations in tumors. And early work by Luis Diaz and colleagues actually was able to show that those tumors with high mismatch repair deficiency or microsatellite instability high, regardless of their location in histology, were susceptible to be sensitive to PD-1 axis blockers. And this is what you can see on this slide with the different survival curve and a very, very strong waterfall plot on the bottom right. So this data actually, plus other trials, drove again to agnostic or tumor agnostic approval of microsatellite instability as an immunotherapy biomarker. So again, we have a second genomic metric from the tumor associated with sensitivity to immunotherapy. One interesting thing about mismatch repair deficiency is that it's actually clustered to some extent in a few tumor types. And if you can see in this slide, where a large number of tumors from different locations were analyzed for microsatellite instability, and this was using not a clinical rate assay, but whole exome sequencing, it was evident that 3 tumor types actually contribute or have the highest frequency of microsatellite instability, which are colorectal cancer, uterine carcinomas, and gastric carcinomas. So this opens the question of when to test microsatellite instability. Should we test every tumor? Some institutions test only these 3 tumor types with a high frequency. Some institutions test more. But what is interesting is that there may be slight differences in the cut points that need to be factored that we're currently learning about. But it is, at this point, a viable biomarker for immunotherapy. And again, the testing approach varies a little bit depending on the context. And talking about testing, it's really important to see, as you can see in this slide, that we have been testing for microsatellite instability way before it became a biomarker for immunotherapy. And it was a common marker used for patients with Lynch syndrome and other problems. So there are currently a number of tests that can be used in the clinic to test for microsatellite instability, and you can see them in the table, in the figure. The upper one is the PCR. So this is essentially a capillary electrophoresis test where we test for 5 mononucleotide markers, and it has some advantages relative to sensitivity. But a very commonly used test is also immunohistochemistry, generally for 4 IHC markers, as you can see in the center panel. And the absence of mismatch repair proteins in tumor cells can actually be an indicator of mismatch repair deficiency, and we generally can test that very quickly in the clinic. Many institutions do both, actually do the IHC as a screening and then confirm with molecular testing, and more institutions are now using next generation sequencing, as you see in the bottom panel, that has, again, the advantage that it can come in a panel, so we can simultaneously test for many genes, tumor mutational burden, and microsatellite instability all together. So it's like a one-stop shop and can provide information for both biomarkers for targeted therapy and also immunotherapy.
Thank you, Kurt. I think, you told us you gave us a lot of data about this topic. But I think one important question is, do we think that these assays are either underused or overused or used optimally? Are there existing algorithms how to navigate through all of these very important tests that have very important implications for different tumor types, or that are tumor agnostic, for different medications or common medications? How would one community oncologist and labs, community facility labs, navigate through this?
Yeah, it's a difficult question. I think the complexity and the speed in which changes, I think, demands, to pay a lot of attention. One way, that I advocate for is essentially continue medical education, and to some extent also try to get some level of specialized care, so that you have to you can somewhat manage the information that comes out. In general, guidelines that are widely available, like such as NCCN, capture all of these aspects, and they're updated very frequently. So I think the access to information is not the problem. But the volume of information and the speed at which changes, I think, demands special attention. And then relative to the labs, I think it's a challenge too. Labs need to adapt quickly, update the assays, and the testing. And I think it's ultimately it's an educational process that needs to be continuous. And I think we need to be work in tandem, between the labs, the clinics, and ultimately our patients. Sometimes the patients, they learn about the treatments and biomarkers, and they come to us and they educate us too. So I think it's a little bit of the three-way educational process, but needs to be a continuum to be able to be successful.
Mike, thank you very much. Now, let me try to wrap this up and put it together. So today we discussed that biomarkers can be used to support optimal cancer management, that there are several ways to measure genomic biomarkers, such as Sanger sequencing, qPCRs, and next-generation sequencing. We discussed multi-gene panels are preferred over single gene testing. And we also discussed immune checkpoint inhibitors, blocking cancer-mediated immune tolerance, and that there are different cutoffs and different PD-1 assays and scoring systems. And also that biomarker tests vary. We have TMB assays that can have significant differences amongst themselves, and that MSI is preferentially tested in tumor types with high prevalence using IHC and PCR. So thank you, Dr. Schalper, for that very interesting and difficult discussion. I would like to close out this program with some SMART goals, which are smart, measurable, attainable, relevant, and timely. And our SMART goals are: follow guideline recommendations for biomarker testing, utilize multi-gene panels where feasible for genomic biomarker testing, recognize the benefits and limitations of the testing methods that you employ, and understand the implications of the test results, pathogenic versus non-pathogenic, actionable versus non-actionable, tumor staining versus normal tissue staining, and the requirement of testing for a given therapy. Again, thank you, Dr. Schalper, for our discussion, and thank you to our audience for joining us today.